Welcome to the deep dive. This is where we take, those really dense clinical sources and pull out the key takeaways so you don't have to.
Mm-hmm.
Today's mission is, well, it's pretty huge. We're looking at the whole sweep of reproductive health.
Yeah, the full journey.
Right, starting from that big decision to even try conceiving, then navigating the challenges if infertility pops up, and going all the way to the biological endpoint, menopause.
And our sources, they lay out this sort of clinical roadmap, but it really highlights how often our body's schedule, clashes with our life plans.
That clash, that biology versus planning idea, that's really central today, isn't it?
Absolutely.
Yeah.
Because we tend to talk about fertility just in terms of, like, the physical act itself.
Yeah.
But we really want to ground this conversation in that critical first step. It's the decision, the big discussion, the health check-ins.
Yeah,
That all needs to happen way before anyone even thinks about trying.
right.
Understanding this whole life cycle is just, well, it's essential for understanding both the successes and the struggles.
Okay, let's unpack this then. Starting right there, at that decision point, you might think, okay, we just stopped using the pill or whatever. But the sources really stress this starts with a conversation, a really complex one sometimes.
Oh, definitely. It's rarely spontaneous for most couples, I think. You've
Yeah.
got major individual things to align first.
Like what?
Well, career goals, for instance.
Mm-hmm.
Are both partners okay with potentially pausing a career?
Mm.
Is there an assumption one person becomes a stay-at-home parent? That's a huge one.
Mm-hmm.
And, relationship stability. Are we talking dating but really committed? Or married, living together? Those dynamics really change how you approach it.
And the timing. It always feels like the timing is impossible, right? The sources mention waiting for money or finishing school or getting established.
Yeah.
But then they say there's never really good timing.
Exactly. Life happens, doesn't it? A job loss, maybe a move, a health issue comes up.
Yeah.
Trying to perfectly control biology around life's chaos.
Yeah.
It's tough. And we can't forget the sort of non-negotiables,
Yeah.
like religious beliefs. The sources specifically mention Catholic patients, for example, who might not use hormonal contraceptives. That immediately changes the whole planning toolkit. You have to rely on different methods then.
Which we'll get to later, yeah.
Yeah.
And health, too, right? That's another big one.
Yeah.
If someone has a chronic condition, like type 1 diabetes.
Oh, yeah. That needs really careful management already.
Yeah.
Adding pregnancy planning, that needs immediate, proactive medical talks. Big time.
It's all risk management, basically.
Pretty much. So, okay, let's say the talks happen, the decision is made, the effort starts. Now we move into the clinical side. And this is where we start defining the struggle, if it happens. Infertility.
Okay, let's get those definitions straight, because people mix these terms up all the time.
Right. So the main clinical one is infertility. Basically, no conception after at least 12 months of regular, unprotected sex.
12 months. That feels like a long time if you suspect something's wrong. Why that specific time frame?
It does feel long, I know. But it gives doctors a statistical baseline, really. It helps rule out, just simple timing issues or chance. But look, it's not totally rigid.
Okay.
If someone comes in and they already have a known hormonal issue, maybe PCOS, polycystic ovary syndrome, or hypothyroidism and underactive thyroid,
Right.
or maybe they know the male partner has some issues,
Mhm.
then testing often starts way sooner because you kind of anticipate a challenge there.
Got it. So if that year passes without success, or if testing starts early because of those known issues, what other terms pop up?
Well, you have subfertility. That's when there's difficulty conceiving because both partners have reduced fertility, sort of a shared challenge.
Okay.
And then there's secondary infertility. This one's particularly tough emotionally, I think.
How so?
It means you've had a successful pregnancy before, carried to term, delivered, but now you can't conceive again. Or sometimes it means you can conceive, but you keep having miscarriages. You can't sustain the pregnancy.
So it's not just about getting pregnant, but staying pregnant too.
Exactly. That distinction is really important clinically.
Okay, so if the decision phase is all about life plans clashing with biology, this next part feels like biology clashing with biology almost, or outside stuff interfering.
Yeah, that's a good way to put it. It's kind of amazing how much external things, lifestyle choices, environment,
Yeah.
how much they can derail conception.
Let's break that down. Male factors first.
Sure. So we know the obvious ones: substance abuse, alcohol, drugs, smoking. But the sources highlight environmental toxins too.
Like what kind of things?
Well, think about jobs with high exposure. Maybe an X-ray tech who isn't always using proper shielding. Or someone working with certain industrial chemicals day in, day out.
Wow, okay. And prescription drugs. That came up as a big, often overlooked factor.
Huge. And the sources detail 5 specific ways medications can hit male fertility. It's not just one thing.
5 ways. Okay, what are they?
So first, a drug can be directly toxic, just lowering sperm count or quality. Second, it can mess with the pituitary gland, the control center for hormones.
Right.
Third, it can actually affect sexual function itself, problems with ejaculation or maintaining an erection, which is obviously frustrating.
Yeah.
Fourth, it can lower libido, just the desire. And fifth, this one's kind of sneaky, it can block the sperm's ability to actually fertilize the egg, even if the count looks okay. And of course, we have to mention past cancer treatment. Chemotherapy is just really toxic to fertility, unfortunately.
Yeah. And for female factors, similar lifestyle stuff, I imagine.
Yeah, a lot of overlap. Substance abuse, definitely.
Yeah.
Diet plays a role. Being significantly overweight or underweight could disrupt things. But stress seems to have this really nasty cyclical effect for women.
How does that work?
Well, stress itself throws hormones off balance, which messes with your menstrual cycle. But then the stress of trying and not getting pregnant, that just adds more stress, raises cortisol.
And makes it even harder to conceive.
Exactly. It becomes this vicious cycle
Yeah.
of self-fulfilling prophecy driven by stress.
That sounds incredibly difficult. What about extreme exercise? The sources mention that.
Right? Like elite athletes, Olympic level training, that kind of intense, sustained physical stress. The body basically interprets it as this is not a safe time to carry a pregnancy. So it can shut down or disrupt the reproductive functions.
Makes sense from a biological preservation standpoint, I guess.
It does. And beyond lifestyle, you've got underlying health issues, again, like PCOS, type 2 diabetes, thyroid problems, all impacting that delicate hormonal balance. Oh, and a quick point on past infections. Untreated STDs can cause scar tissue, especially in the fallopian tubes, which is a major barrier to fertility.
Okay, so lots of potential roadblocks. If stress and environment can hinder conception, let's flip it. How do people take control? Either planning for pregnancy meticulously or deliberately avoiding it with contraception.
And it's important to see contraception as both things, right? A planning tool and an avoidance tool. Again, respecting those cultural or religious views is key. Like we mentioned with Catholic patients, maybe not using hormonal methods.
So for those relying on non-hormonal planning, those fertility awareness methods are crucial. What are they exactly?
They require a lot of diligence. The simplest is maybe the calendar method, basically estimating ovulation around day 14 of the cycle and avoiding unprotected sex then.
Seems straightforward, but maybe not super precise.
Not always, no.
Yeah.
Then you have the basal body temperature method. The idea is your body temp goes up just a tiny bit after you ovulate because of progesterone.
Okay.
But the catch, you have to take your temperature exactly the same time every single morning, right when you wake up, before you even get out of bed.
Wow.
And you need to track it for like 3 whole cycles to see a reliable pattern. It takes serious commitment.
That sounds like a lot of pressure first thing in the morning.
It really can be. And finally, there's the mucus method. Tracking changes in cervical mucus. It gets thinner, more slippery around ovulation. Again, requires paying close attention.
Okay. And then there are barrier methods like condoms, diaphragms, or emergency options like Plan B.
Right. Situational methods.
But speaking of planning and awareness, you mentioned a really surprising reason someone might not conceive, something from the sources about medication misunderstanding.
Oh, this was eye-opening.
Yeah.
It's a real case study in how things get lost in translation. Imagine someone maybe put on the birth control pill really young, like 13 or 14.
Okay.
But not for birth control. Maybe for heavy periods, bad cramps, even acne. They just always called it their period medicine.
Right. I know people who did that.
Exactly. So now they're, say, 28. They decide they want to try for a baby. They stop taking their period medicine, but maybe they replace it with a vitamin or something else. They literally had no idea they were on a low-dose birth control pill the whole time. They thought it was just for symptoms.
That is, wow, a huge communication gap between doctor and patient over years.
A massive one. It shows how important clarity is.
Okay, so let's say natural efforts, even with careful planning, haven't worked. We move into assisted reproduction. What are the first steps there?
Usually we start with less invasive options, like therapeutic insemination.
What does that involve?
It's basically placing sperm either from the partner or a donor directly near the cervix or inside the uterus using a simple mechanical method like a syringe. It bypasses potential issues with sperm travel. It's less costly and less invasive than, say, IVF.
Right, IVF, in vitro fertilization. That's the one most people think of.
It is. IVF involves retrieving eggs from the ovaries, fertilizing them with sperm in a lab. In vitro means in glass, like a petri dish, and then transferring the resulting embryo back into the uterus.
It sounds straightforward when you say it like that, but the sources emphasize the toll it takes, right?
Oh, immensely. You have to understand, if you're considering this, the strain is enormous.
Yeah.
Financially, it's often tens of thousands of dollars for one cycle. It doesn't always work. It's definitely not fail-safe. And the emotional roller coaster,
Yeah.
the hope, the waiting, the potential disappointment if it fails, it can be absolutely devastating for individuals and couples.
And then there are even more advanced techniques, often with serious legal and ethical layers, like cryopreservation, freezing.
Yeah, freezing eggs or embryos. This is often done proactively, maybe before someone undergoes cancer treatment like chemo, which we know can damage fertility.
A way to preserve future options.
Exactly. And we see many wonderful, successful pregnancies from frozen eggs or embryos. But it's not perfect. The sources do mention, though rarely, seeing some medical anomalies potentially linked to the freezing and thawing process. Things like Turner's syndrome, or even, in very rare tragic cases, severe congenital defects. It's important to know it's an amazing technology, but not without any risk.
Okay. And then the one with probably the most complex legal issues, surrogacy.
Absolutely. Rule number 1, get a specialized lawyer involved right from the start. It's essential.
Why so critical?
Because the contracts are incredibly complex.
Yeah.
Plus, the process of choosing and vetting the gestational carrier of the surrogate is intense. They need to be in good health, ideally have had successful pregnancies before, not too many C-sections, because that increases risks.
And the legal what-ifs, that's where it gets really tricky, isn't it?
That's the potential nightmare scenario. What if it's twins, but the contract was for one baby? Who's responsible, legally and financially?
Oh, wow.
Or what if prenatal testing shows a serious issue, like Down syndrome? The intended parents might want to terminate, but what if the surrogate has strong personal or religious objections to abortion? You're looking at a huge legal battle over bodily autonomy, contracts, parental rights. It gets incredibly messy.
And there's a key point about the surrogate's genetics, right?
Crucial point. For it to be a true gestational surrogacy contract, legally, the surrogate cannot use her own eggs. She's only carrying the pregnancy.
So the embryo is from the intended parent's egg and sperm, or donor gametes.
Correct. If the surrogate does use her own egg, it's legally considered an adoption, not surrogacy. Totally different legal framework, rights, everything.
Okay, that's a lot to consider with assisted reproduction. Let's shift gears now towards the later stages of the reproductive lifespan. Menstrual issues are really common. Can we quickly define some key terms for pain and bleeding problems?
Sure, we can group them. Dysmenorrhea, that's the general term for painful periods. Amenorrhea means no periods at all.
Okay.
Then for bleeding pattern issues, menorrhagia is excessive bleeding, really heavy flow, or lasting too long. But it happens at regular cycle intervals. The timing's normal, the amount isn't.
Got it. And the other one?
Metrorrhagia, that's bleeding, could be light or heavy, that happens between periods. Irregular timing.
And the sources make a distinction within painful periods, primary versus secondary dysmenorrhea. Why is that important?
It tells you why it hurts. Primary dysmenorrhea means the period itself is the problem. It often starts a little while after the very first period. Maybe a teen is fine for a few months. Then it gets painful.
Okay.
The key thing here is the pain tends to decrease as they get older. It's most common in, say, the 15 to 25 age range. Symptoms are usually cramps, maybe radiating pain to the back or thighs, sometimes nausea, headache.
So if the pain doesn't get better with age, or if it starts much later in life?
That's a big clue. It might be secondary dysmenorrhea. Here, the pain isn't just the period itself. It's caused by some underlying issue.
Like what?
Could be endometriosis, uterine fibroids or tumors, cysts, maybe pelvic inflammatory disease, PID. This type is more likely to show up later, maybe ages 30 to 50. And the pain isn't just during the period. It can happen anytime in the cycle because the underlying problem is always there.
Makes sense. And treatments cover a wide range.
Yeah, from simple things like NSAIDs, ibuprofen, and naproxen, or using oral contraceptive pills to regulate hormones and reduce pain, all the way to surgical options. Things like a DNC, which is a dilation and curettage, or endometrial ablation.
What's ablation?
That procedure essentially destroys the uterine lining to stop heavy bleeding. But big caveat, it's generally not for anyone who still wants to get pregnant because it causes significant scarring.
Right. And the final surgical option?
A hysterectomy, removal of the uterus, that's usually a last resort for severe debilitating problems.
Okay. Which brings us logically to the biological end of reproduction, menopause.
Yep, the inevitable transition. We usually talk about perimenopause first. That's the lead up, the gradual decline in estrogen. It can last several years. Hot flashes often start here, maybe night sweats, cycle changes.
Men?
than postmenopause. Clinically, that's defined as 1 full year after your very last menstrual period.
What if someone's already had a hysterectomy, so they don't have periods to track? How is menopause diagnosed then?
Good question. In that case, doctors rely on blood tests, specifically checking the FSH level. That's follicle-stimulating hormone.
How does that help?
Well, as the ovaries stop responding and estrogen drops, the brain tries harder and harder to stimulate them. It pumps out way more FSH. So a consistently high FSH level in the blood confirms postmenopause, even without periods as a guide.
And that drop in estrogen isn't just about periods stopping. It brings real health risks, doesn't it?
Absolutely. Estrogen offers a lot of protection. When it declines significantly, your risk increases for several things. Heart disease, especially atherosclerosis or hardening of the arteries, osteoporosis, the thinning of bones, macular degeneration affecting eyesight, even cognitive changes.
So what's the standard approach to managing those risks and symptoms like hot flashes?
HRT, hormone replacement therapy, is often used. It's generally the most effective treatment for troublesome symptoms, like severe hot flashes and vaginal dryness.
But there are risks with HRT too, right? The cancer link comes up often.
There are nuances, yes. The main concern is with combination HRT that's estrogen plus a progestin. Studies show it can slightly increase breast cancer risk, but specifically if used continuously for more than 5 years.
Only after 5 years.
That's what the data suggests for the increased risk. And importantly, the sources also state that this elevated risk seems to disappear once you stop the therapy. So it's a risk, but one that can be managed and is time-limited based on duration of use.
Okay, so it's a risk-benefit discussion with your doctor.
Oh.
So, reflecting on all this, we've traced this huge arc from the hope and planning of wanting a child through the potential pain and complexity of infertility and landing at the unavoidable biological changes of menopause.
Yeah, it's quite the journey. And what really stands out from the clinical sources consistently is how deeply connected these physical stages are to emotional and psychological well-being.
Right, you see it across the board, whether it's dealing with infertility, managing chronic period pain, or going through menopause. The emotional strain is always flagged as a major factor in the clinical picture.
Yeah, the standard nursing diagnoses that pop up again and again in these contexts are things like risk for disturbed body image, sexual dysfunction, situational low self-esteem. They're considered core parts of the clinical problem.
Which leads to a really interesting final thought, doesn't it?
It does. It makes you wonder.
Hmm.
If these processes, menstruation, conception struggles, aging, are fundamentally natural biological events,
Yeah.
why is the psychological impact so profound? Why is this feeling that your body is somehow failing, whether it's failing to conceive or failing by aging, such a central part of the clinical experience and treatment?
Yeah. What does that say about our wider societal narratives? About health, about womanhood, maybe? What do we need to unpack there to better support people through these very normal, yet often very difficult biological realities?
That's the question to ponder, I think. How do we better align the biological facts with the emotional and mental support needed?
A really powerful note to end on after covering so much ground. Thank you for walking us through all that source material today.
My pleasure. It's important stuff.
Absolutely. We'll catch you on the next deep dive.